Okay, we're going to talk about gastrointestinal ultrasound. And you can see on ultrasound all the way from the salivary glands down to the rectum on ultrasound, which is pretty interesting. On all the structures in between, including the liver, the biliary system, the stomach, and the pancreas, and the spleen. So we're going to be talking about all these structures, or most of them. We're not going to talk about the salivary glands. That's for a separate talk on head and neck ultrasound, but we will be covering the main ones here. Starting with the esophagus. The esophagus lies just to the anatomic left of the trachea in most individuals, and you can see the shadow caused by the air-filled trachea, and you'll see it just on the side of that shadow from the trachea. Pretty easy to see. The way it's been drawn here, I think, is not always true. I find it off to this side, the left side, more often than not. But we do see the trachea here and its shadow coming down. Clearly, the thyroid gland is visible up here. Again, not part of the gastrointestinal tract, but boy, does that look beautiful on ultrasound. So yeah, you'll see your esophagus sort of hanging out over here. And if you're not sure what you're looking at, you can always have the patient swallow, and you'll see whatever spit is in their mouth, it'll be cruising through the esophagus. You can see it both in the short axis and the long axis. Okay, we can see it over here. The esophagus is right next to that air-filled trachea with its shadow coming down. Here's your esophagus. You can make out those layers there of the esophageal wall, the varying layers, thus hypoechoic outer layers, very typical of all of the intestinal tract throughout the entire body, as you'll see. Again, here's your thyroid, your carotid, and it's sort of just wedged in between all these organs right here. Very easy to see. You can stretch out the probe into a longitudinal plane, and you'll see the esophagus stretch out across the screen. Now, the stomach is interesting. It's hard to see on ultrasound because normally it's filled with air, but occasionally there's fluid in the stomach, and once that's the case, then you can actually make it out. And so in this case here, we're looking in that left upper quadrant. This happens to be the spleen here, the kidney is right here, and the spleen and the kidney sort of come in contact with one another. And when there's fluid that's intraperitoneal, you'll see it layer out between the spleen and the kidney. But in this case, there's fluid on the screen for sure. It's this black anechoic fluid here, but it is not between the spleen and the kidney. Rather, it's out here in the stomach. Stomach is more anterior to the spleen. This is a coronal plane. We've got the indicator towards the patient's head. We're coming from the side of the body. So it's as if we took the probe and we just put it like right here between these two ribs. And we can see the spleen here and the stomach here. This is a CT scan. The stomach's got this fluid in it, this air up here. And you can see that when you're really, if you're pretty anterior, the kidney's not even in the picture. You'll just see some fluid here within the stomach adjacent to the spleen. Some people mistake that as intraperitoneal fluid, when in reality you know now that intraperitoneal fluid layers out between the spleen and the kidney. It's not found separately in this encapsulated structure here, the stomach. A couple more examples of the stomach here. You can see when there's fluid in there, you can make it out. This is some fluid here in the stomach. This is all the spleen up here. Here's the kidney over here. And there's some air and stuff getting in the way and making the picture difficult to see. Again, spleen, kidney, stomach right here. The depth's a little bit too deep on this image. You can shallow that up a little bit, and the structures will appear much larger on the screen. But that's the idea. Your anechoic stomach is seen adjacent to the kidney and the spleen. Now, what about the intestines? You always hear about ultrasound, air being the enemy of ultrasound, and what can ultrasound really diagnose in the intestines? Actually, it does a pretty good job. It can definitely see intraluminal gas, as we're about to see, but I can also see gas within the wall of the bowel as well. And so we'll be seeing some examples of that eventually. You can see a small bowel obstruction with very good accuracy, incredible accuracy actually, in some cases better than CT scan, but definitely better than an X-ray. And then appendicitis is also seen in ultrasound. We'll talk about that. And then you can even see free intraperitoneal air. The problem, though, is with this gentleman here with this very large distended abdomen, and this type of body habitus does not usually bode well for ultrasound. Just sort of being frank about it, this guy was probably better served in a CT scanner. However, Should this really be a small bowel obstruction, then ultrasound will fare actually quite well, and in that case, and ultrasound for small bowel obstruction, no matter how distended or large a patient seems, does quite well. Appendicitis on this guy, another story. This would be nearly impossible to find his appendix because he's such a large individual. Now, normal intestine does have this sort of layered appearance. You can see there's air there within the lumen of the bowel. You just sort of stuff you can't make any sense out of. It's just normal looking layered bowel here. But you will see intermittent peristalsis. And just think about the wall thickness of the bowel with large intestine is usually less than 4 millimeters, and the wall thickness of small intestine is being less than 3 millimeters. So here's a loop here, mid-peristalsis of small intestine, and you'd want to make sure that this wall, this hypoechoic outer layer here is the wall, and you would measure this region right here, down here, make sure that's less than 3 millimeters in small bowel. This is just some vasculature, probably some iliac vasculature down here. Now, with the small intestine, another way to tell it is that it's got the plicae circularis going around here, and so you can actually make out some of these structures here, the plicae, as you can see on the screen up here. And so these plicae circularis really define that structure is small bowel. Whereas with large intestine, you've got these haustra, and that's what these large structures are right here. These are haustra. Right there. And yeah, just from this, oh, here we go. You can see maybe some of this haustra coming along here in this cross-sectional area here drawn by Netter. Haustra, 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 haustra here. And this is what it looks like on ultrasound. Pretty distinct. You can see these regions here, which is distinct from plicae circularis. The plicae will go all the way around the bowel. You can see it if you get towards the edge of a loop of small bowel. You will see it go all the way across, whereas with large intestine, the haustra definitely does not go all the way across. So it's not as distinctly crossing over as you get to the edge of this on ultrasound. Towards the edges of this loop of small bowel, you'll see these plicae go all the way across. And that's what helps me sort of distinguish large and small bowel. Now, which transducer are you going to use to look at the bowel? When you're up in the neck and you're in the esophageal area and you're down towards the appendix, especially in thin patients, this transducer here is really good. This is the high-frequency linear transducer that's good for your average or maybe your thin type of patient, but definitely patients looking superficially like the esophagus, this will always be the probe. Now, when you've got a larger patient or if you're looking at small bowel, I think this is the best probe to use for small bowel obstructions, differentiating small and large bowel obstructions, and also depending on the patient, the appendix. So in larger patients, I would use this probe for the appendix, and then smaller, thinner patients, I'd use this probe. Do I have a certain number, a size, a BMI? Nah, I just kind of, if I'm looking at the appendix, I sort of usually start with this probe. Or if I'm looking at a patient who I know is going to be a difficult appendix scan, I would just jump to this probe over here because this is going to have lower frequency, therefore better penetration, though not as high of resolution as this transducer will. Now, the technique that you want to use is what we call mowing the lawn. You want to start in that right upper quadrant and look for that ascending colon, and it's usually pretty easy to see with the haustra, and you kind of know where it's supposed to be. And then you just follow that ascending colon down to the right lower quadrant, and then you'll see the cecum's blind-ended loop down there many times. And then this cecum should lead you to your terminal ileum, where you'll see your appendix sort of hanging off. And the appendix can hang off in all different directions here. But once you see that TI, it looks like a little flower when it's mid-peristalsis, you know you're right near the appendix. And then what you're going to do is you're going to march right back up the ascending colon again, and then go across, your transverse, and then down, just up and down the body this way. Eventually you'll come down to where the sigmoid is, down the pelvis, and you should see the rectum behind the urinary bladder. If the urinary bladder doesn't have enough fluid in it, then you may not actually make out the urinary bladder very well. But it's this kind of thing. You're moving up and down and mowing the lawn, so to speak. You did this, and notice the probe here is in a transverse plane with the indicator to the patient's right, and then you would also then do the same thing in a sagittal plane, and then just kind of march back and forth with the indicator towards the patient's head, crisscrossing your steps that you made in your transverse plane. And so you've covered all portions of the abdominal cavity, And more often than not, you've come up to what you believe is a leading diagnosis, usually 2 or 3 minutes into this exam. Though sometimes this is the one study that does take me longer than most other studies do. I might spend as much as 5 to even 7 minutes performing a point-of-care ultrasound of the intestines. Now, the problem, though, is the air in the intestines. We've talked about that being the enemy of ultrasound. One of the things you can do is you can have the patient take their right leg and cross it as far over as possible, their left leg. And I think what this does is it makes it easier to compress loops of bowel, because that's what you're really trying to do to get to the pathology, is that your normally loops of bowel should be easily compressible, but when there's pathology there, disease states of the intestine result in decreased peristalsis, bowel wall thickening, less gas within the lumen of these bowels. And so when you're compressing these abnormal loops of bowel, you can really see the pathology there, the small bowel obstruction, the appendicitis, the intussusception, the diverticulitis. And so when you have those things going on, having the patient cross their right leg over their left leg does seem to keep everything in sort of an anterior-posterior plane. So when you're making your compressions, the bowel's not squirting out to the side as much. I'm not really sure why we have them cross their right leg over the right leg, to be honest with you, but that's the it does seem to help, and that's my theory, is that it keeps things more anterior and posterior. Now, talking about the appendix, boy, the normal appendix is difficult to see when it's not very swollen, and so the idea is to compress the abdominal wall musculature, seen here, all the way down as far as possible, so that the psoas muscle, seen here, here's an iliac vessel, psoas is going to sandwich the appendix between the psoas and the abdominal wall musculature. And sometimes you'll get lucky and you'll see a normal-looking appendix here. Now, normal-looking appendix is defined as a compressible loop, so it's not, it doesn't maintain its round shape. It goes ovoid on you, so to speak. An abnormal appendix will maintain a round, non-ovoid shape with when you apply compression to it. So therefore, a fluid-filled or swollen appendix, appendicitis, it does not compress. But a normal appendix does compress down, and it should be less than 6 millimeters. Fucking keynote. Oh my god. You are gonna close. You are gonna open. So normal appendix should be less than 6 millimeters in diameter. And in fact, this one here is 4.3 millimeters, so that is normal. Now, again, you're compressing in that right lower quadrant, trying to get abdominal musculature to go down to psoas. You're compressing, you're looking all around, and you know the patient's telling you that's where the pain is. And all of a sudden, the appendix might pop its head out at you, and then it's gone again. And so when you think you see the appendix, hit freeze. And you can always cine back and see where that appendix was. Or go back and look for it again in live ultrasound. Either way, what you're looking for is sometimes an appendicolith. That's a stone that blocks the lumen of the appendix. That's what's causing the appendicitis, that the contents of the appendix cannot drain because there's a stone blocking its lumen. So it gets more and more swollen, and eventually it gets so swollen that the blood supply can no longer get to it. It gets necrotic and perforates. You want to look for periappendiceal fat. When there is inflammation in the appendix, the periappendiceal fat starts to get more echo bright. And then normally, we talked about those 3 rings of the mucosal walls of the intestines. You start to lose those 3 rings on ultrasound when you have acute appendicitis. All right, so this is the technique in a live mode here. Here's the iliac artery and vein, and we can see abdominal wall musculature up here. I see psoas over here, and this is the appendix. This is just a normal looking appendix, blind-ended tube here that is less than 6 millimeters from wall to wall. And we can see it kind of coming across the screen here and coming around. But that's the technique. Here's Again, what we're looking at is psoas muscle now seen in a longitudinal plane. We've got the probe indicator towards the patient's head, and this is the abdominal wall up here, and we can see a normal-looking appendix with its blind-ended tube here, just sort of sandwiching out between the psoas and the abdominal wall musculature. Another example here, this is your psoas muscle down here, and we can see the appendix coming right across. I don't know if you can see, here you go, right across there. Normal appearing caliber, just off the bat looks like it's pretty compressible here, and I would obviously stop and drop calipers and measure that distance to make sure. Iliac vessels are seen down here. And here's what that terminal ileum looks like. It looks like a little cloverleaf. I don't know if you saw that here. You can see that cloverleaf design here. That's very typical of your terminal ileum. And when you see that terminal ileum, you know that the appendix is somewhere around it. I don't see the appendix on this screen, but it's near that thing. Here's another example of acute appendicitis. This one actually shows appendicitis. Here's the appendix down here. The psoas muscle is down here, abdominal wall musculature up here, and as we're compressing, we see this non-compressible tubular structure actually measures almost a centimeter, 9.7 millimeters in its diameter. So that would be a positive appendicitis there. Another example here, we see psoas muscle here. They're compressing so much that psoas is coming all the way to the top of the screen. And we're just marching through, and abdominal wall musculature is up here. We see some peristalsing loop of bowel here with some comet tail shadows, dirty shadows coming down. There's some fluid-filled loops of bowel over here. That's okay, we're just compressing. And, you know, at least so far, I don't see any appendicitis on this screen at all. Iliac vessel over here, psoas. And we're just doing this graded compression technique with these loops of bowel. They all compress out of the way. And as you're doing this exam, the patient's kind of looking around the room. They're sort of nonchalantly, this patient does not have appendicitis, at least based on the clinical findings and the lack of being able to see it. There's other factors involved too with white blood cell count and other things which we won't get into right now, but there's something called the Alvarado score that I do talk a lot about, which I do like, but just in terms of the ultrasound technique, I don't see an appendix here. This is a fecalith right here. So the appendix is swollen and it's over here, sort of coming off the screen. It's definitely dilated. From 2 to 3, that's 1 centimeter. So you can imagine this is almost a centimeter. It's definitely more than 6 millimeters. This is pretty dilated. And this is the cause of the appendicitis. There's a stone blocking the entrance and exit of the appendix. And so it's getting more and more swollen from its contents. Fecalith, sometimes called an appendicolith. This is a hyperemic appendix. So this is a non-compressible appendix here, definitely appendicitis. And for fun, you can put color flow Doppler on it and you'll see it light up like this. That shows you that there's some infection going on. There's hyperemia, extra blood flow going to help fight an infection. When something is swollen, it gets red, it gets, you know, more blood vessels are going to it, and so you get this ring of fire, we call this, for the appendicitis. It's hyperemia, it's increased blood flow when someone's got an infection. And you can see some other appendices here. This is all pediatric appendicitis. Very nice looking one here. This measures 8.5 millimeters. Here's that terminal ileum adjacent to it. Here's our appendix, 6.7 millimeters positive here. Here is that terminal ileum again. It looks like a little cloverleaf thing. And adjacent to that, we see this hyperemic appendicitis. You can even see the blood flow, the stalk of the blood flow going to it. Here's another fecalith here with its shadow, and yeah, you're starting to see a little bit of hyperemia here in this longitudinal plane of this appendix down here. Another example of appendicitis, we see the abdominal wall musculature, and psoas is somewhere down here. We're compressing, and then this non-compressible tubular structure that also has some periappendiceal fat. See that hyperechoic material starting to mat down around it. When you get some inflammation anywhere in the body, you start to get cobblestoning or hyperechoic material there. Sometimes you'll even see some fluid surrounding it, loss of those normal 3 walls of the appendix, periappendiceal fat. Boy, that's a really hot appendix right there. Another example here of some of that periappendiceal fat I was telling you about. You can see all the hyperechoic sort of material surrounding this swollen appendix. I thought I saw some psoas down here, and part of the clip you'll see psoas down here, abdominal wall up here, acute appendicitis with periappendiceal fat. Just another example here. We see a dilated appendix seen here that's marching out between all this abdominal wall musculature, and down here would be where my psoas is. Okay, switching gears now to talk about the gallbladder, one of my favorite topics because ultrasound is so perfect for the gallbladder. It is one of those times when the ultrasound actually does better than CT scan. So the gallbladder, in order to see it, you place the probe in a sagittal plane. Notice I'm using a large footprint abdominal curvilinear probe. I aim it towards the patient's head. Patient takes a deep breath, and then I follow along that subcostal margin laterally. And as I do so, I'm doing this called the subcostal sweep. Patient takes a deep breath. That's very important. See that? And then you follow along that subcostal sweep, and it's a good place to start to look for the gallbladder. Here is an example here of the main interlobar fissure. This main interlobar fissure, where the right and left lobes of the liver come together, and the gallbladder sits in that fossa. And so it's one of those things that kind of helps act as a landmark. So my portal vein is here, my main interlobar fissure is here, neck of my gallbladder is here. Main interlobar portal vein is here, main interlobar fissure, neck of the gallbladder. Because sometimes you look at the screen, there's some various things on the screen, you're like, which one's the gallbladder? The gallbladder tends to be the most anterior superficial structure when you're looking around the liver for the gallbladder. You'll see the portal vein, very hyperechoic walls to it, and then the main interlobar fissure can be seen between the portal vein and the gallbladder to act as your landmark. And what you're going to do is you're going to roll the patient on their side. And what that does is it gets this pesky duodenum out of the way. You see the second portion of the duodenum rolls right behind the posterior wall of the gallbladder. So if you can roll the patient on their side, those loops kind of get out of the way. Because, let's face it, the air in the duodenum with its shadowing looks a lot like a gallstone with its shadowing. And so to differentiate the two, you'll see the duodenum will have peristalsis to it. And when you move the patient to their side, gallstones are pretty mobile. They may move around, but at least the duodenal loops, that second portion of the duodenum, will get out of the way. And so it's just a matter of, while you're scanning, have the patient take a deep breath. You're fanning that subcostal sweep area, and then you still can't find the gallbladder, or you're having some troubles there with some air in the duodenum. Roll the patient on their side, and those loops will slip out of the way, and you'll get a much easier image of the gallbladder. This is a huge tip. When no one can find the gallbladder, I come in the room, and I just roll them on their side. Got all this bowel gas kind of in the way, you roll them on their side, and suddenly the gallbladder starts to appear. Another technique is X-7. X, the xiphoid process, you can move 7 centimeters laterally and look intracostally, and you'll see between the ribs at the gallbladder.
In the X-7 approach, the X stands for the xiphoid process, the 7 stands for the 7 centimeters you're going to go to the right laterally, place the probe perpendicular to the patient's skin, and more often than not, you're going to find the gallbladder in this general area.
And so this tends to be helpful in patients who tend to be a little bit more larger, rounder, and you'll look more laterally to find that gallbladder. Now, the gallbladder does have very distinct parts to it. It's got a fundus, it's got a body, and then down here has the neck here. Normal gallbladders are up to 10 centimeters in length and about 2 to 3 centimeters in width. And sometimes you get a really funky fold. You'll see these really interesting folds down here in the neck of the gallbladder, and stones can get wedged down there in the neck of the gallbladder. And sometimes you get a fold over here in the top of the gallbladder, and that's called a pharyngean cap. There's not a specific name for when you have a fold down in the neck of the gallbladder, though. The thing about gallstones is that they're quite echogenic and they typically shadow, which makes ultrasound perfect to see them. And so you can see the line of gallstones here with their collective shadow coming down. And the other thing is that they're gravitationally dependent. So as you move the patient around, the gallstone actually appears to be moving here. But what I've done, which you can't tell, is that I sat the patient up. And then when I put the patient back down again, the gallstone actually will travel all the way back down again towards the neck of the gallbladder, from the fundus down towards the neck. And that characteristic, again, makes them very definitive. And that wall along the anterior border a normal wall thickness is 3 millimeters. Once you start getting more and more thickness of the wall here, then you worry about not just gallstones, but you worry about an infected gallbladder, something called cholecystitis. So gallstones alone are called cholelithiasis, but Once you get a thickened gallbladder wall with some fluid around it, it becomes cholecystitis. And that's something that requires antibiotics and ultimately surgery. Now, the duodenum can look a lot like the gallbladder, especially when the gallbladder is contracted. And so even when there's some air in the duodenum causing some shadowing here, you think, uh-oh, is that a gallstone? Nope, that's just the duodenum mid-peristalsis. You know it's the duodenum because it's got this, as I mentioned earlier, this hypoechoic outer wall. That's what this is here, nice hypoechoic outer wall. And you can see here, this structure here, somebody thought could be a contracted gallbladder with some stones in it, but nope, that's just the duodenum with some air in it, and it's peristalsing. That's how you know it's actually the duodenum, because it's peristalsing. Nope, that's not a Wes. A Wes is a contracted gallbladder wall echo shadow. That's not what this is. This is just the duodenum, normal looking duodenum. Now, contracted gallbladders are definitely, they're like little baby gallbladders. They're so cute. They're adorable. And so you can see them with their three walls here, this strongly reflective outer layer, this anechoic middle layer here, and then this minimally reflective inner layer. And when they're contracted, you can see them all contracted down like that. They're absolutely adorable. You can see one over here. Just, I mean, it's so cute. It's like tiny little baby gallbladders, and so I love it when they're like that. And it tells me they're functioning normally, that they eject the contents of the bile, you know, into the intestine there to emulsify the fats. They're working. But the problem, though, is that they can look like duodenums. Here the duodenum is over here, and then here's a contracted gallbladder over here. The difference, though, is that a contracted gallbladder does have a highly reflective outer layer, whereas the duodenum doesn't. It's got this really prominent hypoechoic outer layer. And the duodenum will peristalse. Moving on to the biliary system, the portal triad is where you've got the common bile duct, the hepatic artery, and the portal vein. And so the common bile duct, this green thing here, really runs quite anterior and reliably anterior to the portal vein down here. The hepatic artery is sort of like a fair weather friend, you know, sort of comes and goes in and out of town there, and it's got a smallest caliber of the three. And so the way to find the common bile duct is just to look anterior to the portal vein. And I like to do that when it's in a longitudinal plane. So if you look at what's going on here on the screen, this hyperechoic structure here is the portal vein. The IVC, the inferior vena cava, is down here. More about that in a second. But the portal vein has very hyperechoic walls to it. If you put some flow on here, you'll see that portal vein light up quite well. Some hepatic vein over here. But the common bile duct, in this case, it's very dilated. They're easy to see when they're dilated. That's why I use this example. But you can see how it's got this structure that's a tube that is running sort of anterior to the portal vein, runs anterior to the portal vein. That's how we know we're looking at that common bile duct. Another example here, IVC, portal vein, CBD. Common bile duct is seen up here. We zoomed in on it a little bit here. Portal vein, probably the hepatic artery seen right here, sort of coming and going. And then the CBD again running anterior to that portal vein. IVC is down here. Now, if you just walk through this backwards, you go, okay, there's the IVC. It's definitely the most posterior part of the liver. And then you got the portal vein that's anterior to that. And then you've got the dilated common bile duct here. This is somewhat dilated. Usually the CBD should be of smaller caliber than the portal vein, but you can see since this one's sort of growing in size, it's starting to back up into the liver, and that's what you see here, dilated intrahepatic biliary ducts all coming towards that CBD. This is a very large stone here seen in the distal CBD with something we call choledocholithiasis. The portal vein is this little sliver right here. Huge CBD. It's like 2-point-something centimeters here, and with the intrahepatic ductal dilatation here. Hepatic veins. You can see the right one here is the largest one, and it's draining down towards the IVC. Interestingly, Bob Marley came out of exile, ended up in my ER, and I did an ultrasound on him, and you can see with using power flow Doppler here, this sort of typical pattern here of all three hepatic veins draining down here into the IVC. And then Hugh Hefner came in my ER, which is strange, and the week later, and we can see in his liver he had this typical pattern here of two of the hepatic veins here. I think the main and the right hepatic vein draining down into his IVC here. God, it was a really strange week for celebrity ultrasounds. This here is the IVC now, same vessel there, but now it's stretched out across the screen. Your portal vein is up here. And so the question is, what runs posterior to that IVC? And it's the right renal artery, RRA. Right renal artery runs posterior but perpendicular to the IVC. It's trying to get over from the left side of the body where the aorta is to the right side of the body where the right kidney is. And to do so, it goes posterior to and perpendicular to the inferior vena cava. That's why it's pretty prominent. You can see it back here behind the IVC. So if you stretch out the probe into a sagittal plane, parasagittal to the right, you'll see the IVC coming down the body, and that right renal artery runs just posterior but perpendicular to it. And when you're in a transverse plane, the IVC is actually seen over here to the patient's right. So here's the spine shadow. We've got the indicator towards the patient's right, and so IVC, aorta, and you can see this is the superior mesenteric artery. It looks like a little mantle clock around it here. We can see the splenic vein. It's right here. The splenic vein is this worm that crawls over the SMA. We can see the left renal vein getting nut cracked between the SMA and the aorta, draining into the IVC. And so here's all your liver up here. And this is actually pancreas seen right here. Pancreas is just right next to that splenic vein. And so we can see again on this screen over here, just to review that, aorta, IVC, SMA, splenic vein is crawling over the SMA, and we see the left renal vein getting nut cracked, coming across, trying to drain into the IVC between the SMA and the aorta, left renal vein. So this splenic vein, pay close attention to the splenic vein. On that last image we saw part of the pancreas, the head of the pancreas, and now we're seeing the tail of the pancreas over here. So this more echogenic structure here is the sort of the tail of the pancreas coming down. This is the liver up here. Transverse plane. Once again, here is, go back, this is the aorta seen here. This is the IVC, the SMA. Splenic vein is crawling across here. And so this material right around here, this is all the head of the pancreas. It looks a lot like the liver. I agree, it is hard to differentiate here. But that structure right there is the pancreatic duct running inside the pancreas itself. Okay, so with the gallbladder, the idea is to have the patient take a deep breath. Just to summarize here, you're going to roll the patient left lateral decubitus, and if it's a larger patient, you can go X minus 7, get between the ribs. Sometimes you need to use a smaller footprint probe to do that, like a phased array transducer. Like the same probe you use on the heart, you can actually use on the gallbladder and get between the ribs in a larger individual. Duodenal air can look like gallstones. If you can't find the gallbladder anywhere, there's something called the wall echo shadow. That's a contracted gallbladder around a stone. More on that later, but that's something to think about. And if you're looking for the common bile duct, you want to look anterior to that portal vein. And finally, the spleen. The spleen is a very enigmatic organ. It can be very enlarged in cases such as this patient right here has infectious mononucleosis. They had some submandibular lymph node enlargement, a sore throat, a fever, some malaise, and we saw this huge spleen on them. And so pretty prominent looking structure here on this particular patient. They're usually not that big. Here's the kidney over here. And again, another example of the spleen here adjacent to the kidney. But the question is, what does the spleen really do? That's the question I still have not been able to answer. Maybe the folks at Harvard Medical School can help us.
Ancient mystery, somewhere behind the stomach. I know you're hiding. What is your role? Will we ever know? There'll always be a mystery. Hiding in the peritoneum.
So that's basically the summary of the GI tract. You got the esophagus, the stomach, small intestine, large intestine, the liver, the gallbladder, the pancreas, and the spleen. We got to see them all on ultrasound. And there's all kinds of cool pathology you can see in all those organs as well. We'll get more into that later. But just wanted to give a kind of a primer on how to at least find the organs and what they look like. Thank you.